I'm very aware I'm probably the sole oncologist here, so I'm going to try and at least make the case in 15 minutes for prostate radiotherapy as a good option for men with prostate cancer. It's quite a challenge to cover the whole topic in 15 minutes, so I guess I'm going to primarily focus on primary radiotherapy for prostate cancer, and particularly looking at the intermediate risk group, which I guess is probably the biggest cohort that we see. So the things I'm going to try and cover for you are some general radiotherapy principles for you to take away, so things around fractionation, and also things around the technology that we use, perhaps particularly modern techniques such as intensity modulated radiotherapy. I'll then go on and talk a little bit about the landmark studies in prostate radiotherapy, particularly over the last 10 years. So I guess the main workhorse in UK centres, and I imagine internationally at the moment, is moderately hypofractionated radiotherapy, and particularly we'll focus in on the CHIP study. We're then going to move to something that is very topical at the moment, which is this discussion around the use of ultra-hypofractionated radiotherapy, which has been really on the basis of the studies that were published in the last year, and those were by Vidmark and also the PACE-B study. And then perhaps at the end, we'll just talk a little bit about the future directions of prostate radiotherapy, particularly a little bit about rectal spaces and potentially proton beam treatment. So I won't spend long on this because I know previous talkers have already mentioned it, but again, these are just the long-term outcomes from surgery versus radiotherapy for patients with prostate cancer. We obviously struggle to recruit patients into a randomized trial of surgery versus radiotherapy, because men clearly like to have a say largely on what treatment they have. But just to take up again that for this group of about 1,500 patients who were randomized on a one-to-one basis between monitoring surgery and radiotherapy, most of whom had intermediate or low-risk disease and were followed up for subsequently 10 years, we actually found that in terms of not only cancer-specific survival, but also freedom from disease progression, all of these methods appear to be pretty equal and good. Having said that, I don't think we can simplify things quite as much as saying that surgery and radiotherapy can be offered interchangeably to patients. I think the vast majority of patients do have options, and they need to be informed of all the risks and I guess benefits of both or all treatment approaches. And certainly, I think, whilst we often set ourselves up against the surgeons of wanting to offer something different to surgery, I think, you know, what we really need to be doing is speaking to patients on an individual level about what is the best treatment for them. Even as a radiotherapist, I think there are certain things about surgery which are favourable. I think that the top one I've listed there that favours surgery is the more straightforward option of salvage treatments should you get any form of PSA relapse after surgery. Still, even as we sit here today, performing salvage treatments after local relapse from radical prostate radiotherapy is challenging, and while some centres do offer salvage surgery or other techniques such as HIFU or cryotherapy, that's still a small minority. Equally, I think surgery for patients who have significant LUTs is an attractive idea. Patients who wish to avoid the toxicity of hormonal therapy, patients who perhaps have underlying bowel dysfunction such as inflammatory bowel disease, and also there are a huge number of men out there who just want to know that their prostate cancer is out and that it's gone. I guess those factors that would favour radiotherapy would be there is always an underlying risk of undergoing major surgery. As we've looked at previously, radiotherapy is associated with lower incontinence rates and potentially a better chance of maintaining erectile function. Equally, for higher risk patients in whom we worry about the risk of micrometastatic or metastatic disease to the pelvic lymph nodes, radiotherapy is quite an elegant way of covering those regions systematically, ensuring that we've really covered all nodal bases. For many of those reasons, this is and remains a favourable option for the older patient, particularly a man in their mid-70s and above, or those who are less fit in terms of the surgical risk. So just looking then at some basic radiotherapy principles, things that you'll hear clinical oncologists speaking about. So we always talk about delivering our treatment in fractions. And all this means is that we're going to deliver our treatment in multiple small chunks. That's very, very important. If we delivered it all in one big go, we'd cause catastrophic damage to the local structures in the rectum and the bladder. So we tend to give it in small chunks that allows recovery of the normal tissues, but also enables us to then push in a higher total dose, aiming for good tumor control. The way in which we prescribe radiotherapy is in terms of gray, and all that is saying is the dose absorbed, which, if you want to look at SI units, is in joules per kilogram, so the amount of energy that's deposited into our tumor per kilogram of mass. If we were here talking about prostate radiotherapy 10, 15 years ago, we'd have been talking about what we call conventional fractionation schedules. Probably the most classic of those being 74 gray in 37 fractions, where we're giving 2 gray per fraction. As we move on in due course to talk about the trials looking at moderate and ultra hypofractionation, all we're really saying in that is that we're going to deliver over 2 gray per fraction. There are radiobiological reasons that I won't go into today, which make us think that giving a bigger dose per fraction may be a good treatment option for patients with prostate cancer. And equally, it has obvious benefits in terms of reducing the amount of time patients need to come into hospital for their treatment. Okay, so finally, before we move in to look at the data, just a little brief update, I guess, on the technology of radiotherapy. So these are some pictures taken from the old Newcastle General Hospital many years ago, using old-fashioned radiotherapy machines that were only really capable of delivering dose from certain positions for a certain period of time. If you came for prostate radiotherapy in Newcastle these days, you'd be treated on a machine that looks a lot more like that. So that's a linear accelerator. And as you can see here, what you can imagine is that this treatment head is going to turn around the patient throughout the 360 degrees. It's going to be delivering dose. And whilst it's delivering the dose, it's going to have, as we'll come to in a minute, it's going to have leafs coming in and out that enable us to shape the beam and to really make the high dose region conform very tightly around the area of the prostate gland and the seminal vesicles, as you can see here. So when we talk about intensity modulated radiotherapy, that's really all we're saying is that rather than using fixed field positions, we are now giving it from essentially multiple directions up to 360 degrees with, shaping the fields and the high dose volume such that it conforms very tightly around the prostate. And that has obvious benefits in terms of minimizing the side effects and the dose delivered to the surrounding structures. So this is what is the standard of care for the vast majority of patients receiving radiotherapy in the UK. So this is moderate hypofractionation. The biggest trial perhaps looking at this is the CHIP study, which is a UK-based trial in which patients were randomized between receiving moderately hypofractionated radiotherapy, so that was 60 gray and 20 fractions. There was a further arm of 57 gray and 19 fractions also allowed, versus a conventional fractionation of 74 gray and 37 fractions. So this was a large study of over 3,000 men, predominantly of intermediate risk disease, with small numbers of high risk and low risk also included. Almost all patients received androgen deprivation, both before, during, and for a short period afterwards, with a median of 6 months, essentially. And as I say, a third of men received 74 gray and 37 fractions, a third of men received 60 gray and 20 fractions, and finally a third received 57 gray and 19 fractions. Important to say that all patients simply had treatment to their prostate and seminal vesicles, and there's no nodal radiotherapy, and everyone had their treatment delivered via IMRT. So what this graph really shows is the long-term outcomes in terms of biochemical failure-free survival. And as you can see, between the 74 grey group and the 60 grey group, there was no significant difference at 7 years. The 57 grey group also looks pretty good, but if you look closely, you are starting to see failures, particularly later failures, as the curves diverge. And really, this just shows that the dose is important in prostate cancer, and really the bigger dose we can give to the prostate gland, the better. So moving on to what is very topical, particularly in the world in which we live, where we've got the COVID-19 pandemic, and there are huge drives to reduce the amount of time patients are spending in hospital. This is the move towards ultra-hypofractionation, which has two potential benefits, one of which is delivering treatment in just 5 or 7 fractions of treatment, but also negating the use of androgen deprivation, which we know causes so much toxicity to our patients. So the top study there is by Vidmark, and this was published in The Lancet last year. And this was a study that looked at giving 7 fractions of radiotherapy against a conventionally fractionated radiotherapy of 78 gray and 39 fractions. It's important to note that the control arm in both of these studies had a moderate dose escalation to negate the fact that hormones were not being given. And the second study is the UK-based trial, which is PACE-B, looking at 5 fractions of radiotherapy, again, trialed against a group which could either have received conventional fractionation or moderate hypofractionation, which was just becoming to be the standard of care as this trial was launched. So I'm going to focus mainly on PACE-B, although both trials had very similar entry criteria. Essentially, they only really looked at patients with either NCCN low or favourable intermediate risk disease, and the vast majority were of intermediate risk. Perhaps important to note that they didn't recruit patients with grade group 3 prostate cancers. And again, as we've already mentioned, nobody received any hormonal therapy. So for the PACE-B study, they had a 1-to-1 randomization between 5 fraction radiotherapy, that's 36.25 gray, in 5 fractions, or delivered in 20 fractions or 39 fractions, and that was really depending on the trial center as to what they wish to be the control arm. Again, no nodal radiotherapy was performed, and everyone received treatment via IMRT. So very similar patient groups. We have more data and longer term outcome from the Vidmark study than we do from PACE-B. But in the Vidmark study, they demonstrated that 5-year biochemical failure-free survival was 84% in both groups, and this reached their target for non-inferiority. So I think it's very important, not only as a group, but also when we're informing our patients about these studies, that it's clear that this isn't necessarily a better treatment for prostate cancer, but it's non-inferior to giving it over 20 fractions or more. However, in the 5 fraction group, or the 7 fraction group, I should say, for Vidmark, the acute toxicity in this group was slightly higher, but over time that appeared to settle down and was equivalent in the longer term. We are still awaiting longer term survival data from PACE-B, but they felt at early review of their own toxicity that they were seeing equivalent toxicity in terms of GI and GU side effects. So perhaps unusually for prostate radiotherapy in the UK, where I have to say we're traditionally quite conservative about bringing in new therapies until we have very robust long-term data outcome, really I think primarily driven by the COVID-19 pandemic, centres are increasingly looking at giving patients 5 fractions of radiotherapy, particularly in the favourable intermediate risk group. Just a couple of other things I wanted to just mention today, which are coming into our standard practice. So as we've spoken about before, one of the, if you like, drawbacks of radiotherapy is that we unfortunately do give some dose to the rectum, and perhaps 5 or 6% of patients who receive radical radiotherapy will go on to experience significant radiation proctitis. So there is a move now for introducing space OAR, which is a hydrogel inserted between the prostate and the rectal wall. as a means of reducing the dose of the rectal wall and hopefully reducing long-term toxicity from treatments. We certainly know that it's effective in improving the dose distribution to the rectum. Long-term outcome is awaited to see whether that helps with clinically meaningful outcomes such as the rates of radiation proctitis. And then finally, just touching on proton beam therapy. So again, this is certainly not standard of care in the UK. There may be some centres in the US that are offering it. But very simplistically, protons deliver the dose of radiation in a different way to the photons, which is what we currently use in the UK. And essentially, they are able to deliver all of their dose at a specific depth without quite the same distribution before and after that peak. So the obvious benefits, as you can see from this diagram, is that potentially with proton beam therapy, we're going to be able to cover the prostate gland, perhaps not more conformally, but we will be able to reduce some of that kind of lower dose that surrounds the prostate and heads out into the rectum and other surrounding tissues. Again, it's hoped that this may reduce rectal toxicity and potentially bladder toxicity too. So just in conclusion, I think it's fair to say that radiotherapy is a valid option for the majority of men with localized prostate cancer. As we sit here today, moderate hypofractionation with hormonal therapy is the standard of care for most patients. Particularly in favorable intermediate risk groups, there is a move towards ultra-hypofractionation without the use of hormone therapy. And things like proton beam are in development, but I think as a oncology group, we feel that they should be developed via clinical trials rather than launching these straight into standard practice without robust data. Okay, thank you very much.